Hi, and welcome to a lecture on community-acquired pneumonia. Community-acquired pneumonia is a common and serious illness. The very young and the very old, smokers, and those with cardiopulmonary conditions, alcohol dependence, or immunosuppression, many microorganisms cause community-acquired pneumonia. Mycobacterium tuberculosis is an uncommon and often forgotten cause of pneumonia. Mycobacterium tuberculosis should be considered particularly in those with pneumonia who have HIV or other immune deficiencies and those who are residents of long-term care facilities. Empiric therapy. Initial empiric antibiotic therapy is based on the likely causative pathogen after considering specific risk factors for each patient. Once the etiology is established, it is important to tailor the antibiotic and/or antifungal therapy, paying heed to local susceptibility patterns of bacteria and local epidemiologic patterns. Aspiration pneumonia. Aspiration pneumonia denotes two distinct clinical entities. The first is aspiration pneumonitis, which is aspiration of gastric contents into the lungs with a resultant inflammatory response. The second is pneumonia resulting from the aspiration of oropharyngeal flora into the lungs with resultant bacterial infection. Methicillin-resistant Staphylococcus aureus pneumonia. Methicillin-resistant Staphylococcus aureus is an uncommon but yet emerging cause of community-acquired pneumonia and accounts for about 1 to 5% of cases. Methicillin-resistant Staphylococcus aureus pneumonia is more common in patients with severe pneumonia who require treatment in an intensive care unit and among residents in long-term care facilities. Staphylococcus aureus, both methicillin-sensitive and methicillin-resistant, is about the third most frequent cause of bacteremic pneumonia in the community. Tigecycline is a glycylcycline broad-spectrum intravenous antibiotic that demonstrated non-inferiority compared to levofloxacin in clinical trials of community-acquired pneumonia. It does have methicillin-resistant Staphylococcus aureus activity, but its role in the treatment of methicillin-resistant Staphylococcus aureus pneumonia is still unclear. Here again, because of the lack of data, tigecycline is not indicated in severe community-acquired pneumonia. Corticosteroids in the management of community-acquired pneumonia. Clinical trials studying hospitalized patients treated with either oral or intravenous corticosteroids found a reduction in all-cause mortality in patients with severe pneumonia. Patients treated with corticosteroids were less likely to require mechanical ventilation or to develop acute respiratory distress syndrome. Current recommendations for the treatment of influenza A or B virus infection include the neuraminidase inhibitors oseltamivir and zanamivir. Amantadine is no longer recommended because of viral resistance. Note here that unlike uncomplicated influenza, treatment may be initiated in hospitalized patients with influenza pneumonia even after 48 hours of the onset of symptoms.